Thank you, Chairperson, for all your kind words of introduction, and thank you, Diabetes India, for this invitation. It was a pleasure listening to Professor Basu, and she has very nicely set the context. And so that'd be about half of my slides. So I'm going to go straight to what I'm going to talk about just now. So my talk today is primarily about MSLD and role of dual PPAR gamma agonist, and just sit through while I skip through all the slides that Professor Basu has just shown. So all of these, he has already said the context. Just to reiterate that, MSLD is a big problem when it comes to India, and we need to have very high index of suspicion, and we have to screen for them when they come to you. So anyone who is obese, overweight, or with diabetes, we have to actively screen for MSLD, and you can see like 38.6%. That's the prevalence of MSLD in India, and it's a big concern in the pediatric age group as well. So many of the metabolic conditions go hand in hand. We already talked about obesity, type 2 diabetes, hypertension, high triglyceride levels, and metabolic syndrome. So this is a knowledge attitude practice KP for MSLD that was conducted, and this was significantly low in the Asian patients, and this was done by Sheila Sheikh's group, and they tried to find out that what was the exact knowledge that the physicians had, and it seemed that everybody has heard the term NFLD, but when it comes to actually knowing what exactly it was, many of them didn't know about this. So this is what comes out from the study, that 70% of the patients had low to medium KP score. So we need to be, advocating about this on a regular basis at various platforms. And 50% of the physicians, the mean KP score was low to medium range again. So again, the chicken and egg situation here. Just a brief thing about that, in Indian context, insulin resistance is one of the big concerns, and that would be the basic pathophysiology when it comes to, any of these that we are talking about, whether we're talking about MSLD, whether we're talking diabetes, diabetic dyslipidemia, metabolic syndrome. So the basic fact is that, we have higher insulin resistance, and because of that, we are predisposed to any of these conditions. We have higher prevalence of steatosis and fibrosis, and this is a large study with about 1,500 odd type 2 diabetic patients, showing that 75% prevalence of steatosis and 29% liver fibrosis, which should be diagnosed on time, and we have to be, as we said, very proactive in terms of screening for it. There was also high prevalence and clinical significant liver fibrosis in NFLD patients with type 2 diabetes, and this was published in 2024, very recent publication, and 58.9% of the patient had steatosis, and almost 23% of the patients had significant liver fibrosis. So what we've seen in a sense is that if you look at the continuum, starting from NFLD going through NASH, cirrhosis, and hepatocellular carcinoma requiring liver transplant, the numbers are quite high when it comes to those with diabetes versus those without diabetes. Pathological association between MSLD and obviously increased risk of cardiovascular event and also CKD. And the basic pathophysiology remains inflammation, as you can see in here, which can affect any of the organs. And clinical association of cardiovascular diseases, CKD and MSLD, again, the MSLD patients were 2 times more prone to developing end-stage renal disease with the worst CKD prognosis. So diagnostic approach, I'm going to skip because Professor Basu has talked in details about this. You've basically seen all of these, and FIB4 is what we do in routine clinical practice, and if required, we do a transient elastography as we had been shown, and then we, signpost them if we find that they're at high risk to our, hepatology colleagues, or follow them up if the FIB score is low. And it's only the intermittent group that we, are concerned about. and we need to follow them up on a regular basis as well, because higher the FIB4, we know that the cumulative chances of a cardiovascular disease or all-cause mortality is very, very high. So you've seen all of these. I will show my centers, data in a very short while. Now, just coming to what I'm going to talk about right now is the role of saroglitazar in management of MSLD. Now, why this is novel is this is probably not available in USA at the moment, but this has got DCGI approval in India to be used in the space of MSLD. We know that we had been using saroglitazar very efficiently when it comes to reduction of triglycerides. Now, we have now added a label approval for use in the space of MSLD as well. So we talked about lifestyle modifications. We talked about managing the comorbid conditions, and then what I'm going to talk about now is the pharmacotherapy. So weight loss, 10 to 15% weight loss, we know that can result in significant remission of diabetes, and obviously giving benefits in terms of the comorbid conditions as well, including MSLD. So we need to be very vocal and aggressive when it comes to weight loss, and you see many of the sessions happening in near future, which will be addressing weight loss, because as of now we didn't have dedicated weight loss molecules, but we are going to very soon have things like tirzepatide or the semaglutide 2.4, which are dedicated for obesity management. So other drugs which are used for NFLD still considered off-label, like many of us are still routinely using metformin for some reason, and we, as Professor Basu said, not much of evidence is there for that. Vitamin E is something that we had been using, very efficiently. PPAR gamma agonist like pioglitazone has got data in terms of fibrosis reversal. Obeticholic acid, UTC, again, doesn't have very robust data. Now, first NC approved therapy, and this is saroglitazar, and it's the first NC approved for NFLD or non-alcoholic fatty liver disease in 2020. Before that, we had approval back in 2013 for atherogenic diabetic dyslipidemia, especially targeting the triglycerides. So it's a dual PPAR gamma agonist, and as you can see, the mechanism of action is via both the PPAR alpha as well as the gamma receptors. Via the PPAR alpha agonism, it reduces triglycerides. Via the PPAR gamma agonism, it reduces insulin resistance and controls blood sugar level. So this is evidences for phase 2 saroglitazar efficacy in the NFLD USA study, and it had about 104 patients with NFLD, and the primary objective was change in efficacy endpoints in full analysis of set population from baseline to week 16. And we did see versus placebo, there was an absolute change in the liver fat content, and also reduction in the liver fat content by 10%. And also there was a significant proportion of patients on saroglitazar versus placebo who showed a liver fat reduction by almost 30% or more. Now, effectiveness of PPAR gamma agonist saroglitazar in NASH, and this is a biopsy-driven phase 3 study from India, and you can see in here again the primary endpoint was a decrease in the NFLD activity score, which was observed in 52.3% of the patients without worsening of fibrosis at the end of the study duration of 52 weeks. So efficacy and safety of saroglitazar in real-world studies on MSLD or non-alcoholic fatty liver disease with or without diabetes, including compensated cirrhosis. A tertiary care center experience, again 112 patients. Treatment duration of 52 weeks, and treatment was with saroglitazar 4 mg. And the result was there was improvement in transient elastography parameters according to baseline fibrosis grade, and very often we did see there was a change in grade from F3 to F2 or F2 to F0, F1. So there was a regression of the fibrosis grade. So role of saroglitazar in MSLD, it's a 96 weeks follow-up study from one of my gastro colleagues in the same institute. And it showed that both the parameters that we do by transient elastography, that is the LSM and CAP, reduced. LSM reduced by about 42% and CAP by about 26%. And the patients diagnosed with MASH related cirrhosis without any signs and symptoms of decompensation on endoscopic USG evaluation. So this is again looking into the LSM changes as well as the CAP changes, and you can see there was a very significant decline in both. So in 2022, there were recommendations regarding saroglitazar in NFLD treatment for minimum 12 months duration. And now we have data and label approval, but the minimum duration that you have to use is at least a year if you're trying to address NASH or NFLD. And these are the four major scientific bodies who have recommended saroglitazar for addition for the space of MSLD. One is LI, or the Lipid Association of India. The second one is RSSDI. Third one is Indian National Association of Study of Liver, and the fourth one is Cardiological Society of India. This was my study back in 2018 from our center. This was on saroglitazar's impact on the diabetic dyslipidemia. This was before the label update for the use in the space of MASLD. And this is a routine fibroscan that has been done from our center. This is how it looks, and we have just submitted the data where we had looked into the FIB-4 score as well as the transient elastography parameters in looking for the prevalence of MSLD and also in terms of the intervention with saroglitazar. So to summarize, saroglitazar and MSLD, if we consider MSLD is a metabolic dysfunction associated steatotic liver disease, which is redefined now. So this is the common term that you'd be hearing in near future. Association of at least one cardiometabolic risk factor like obesity, type 2 diabetes, hypertension, high triglycerides, low HDL, or steatotic liver disease is considered as MSLD. You need to have very high index of suspicion and screen actively with diagnostic tests like USG, FIB-4 scoring to begin with, and if required, back that up with transient elastography. And lifestyle modifications remain the cornerstone, along with weight reduction and obviously the pharmacotherapy that we are going to talk about, like saroglitazar has been approved now in India to be used in the space of MASLD, and it can reduce the liver enzyme, liver fat, and also improve the fibrosis score. With this, thank you.